I'm Dr. Morie Gertz, and I'm the chair of the Department of Medicine at Mayo Clinic, Rochester. This ASH meeting has given me every confidence that we are increasing the number of patients cured with multiple myeloma. There have already been some thematic findings that are going to carry directly into our clinical practice. This morning, Dr. Durie, president of the IMF, presented data indicating that 3 drugs at the time of diagnosis provide a longer time without myeloma and a longer survival compared to 2 drugs. And that, I think, is a conceptual change in the way in which we'll be approaching the treatment of newly diagnosed myeloma. We also now have 2 treatments for patients with multiple myeloma that are all oral, and therefore eliminates the need for intravenous infusions and subcutaneous injections. Those 2 regimens include ixazomib, cyclophosphamide, and dexamethasone, and ixazomib, lenalidomide, and dexamethasone, which was recently approved by the FDA as a regimen for the treatment of patients with multiple myeloma. In addition, we found from the HOVON group that the use of bortezomib as part of induction and maintenance therapy provides survival advantage compared to a non-bortezomib treated arm and has very powerful positive impact on those patients that carry the very bad genetic finding of the -17p, which is very exciting for high-risk patients. We also had updates on the very recently approved monoclonal antibody, elotuzumab. That elotuzumab combined with lenalidomide and dexamethasone is providing superior outcomes for our patient population and establishes a brand new class of treatment for patients with multiple myeloma monoclonal antibodies. We heard an update on the use of daratumumab, which has also recently been approved for the treatment of patients who've had 3 prior lines of therapy. And we're finding that daratumumab produces clinically meaningful responses in patients who've failed virtually every known class of chemotherapy, offering new hope to our patient population. We saw a direct comparison of carfilzomib dexamethasone to bortezomib dexamethasone, and in virtually every genetic classification, every subcategory, carfilzomib was both better tolerated and produced better outcomes than bortezomib dexamethasone, which offers tremendous hope for how to use proteasome inhibitors in our myeloma population. A comparison of cyclophosphamide thalidomide dexamethasone compared to bortezomib thalidomide dexamethasone, so-called VTD, VCD, or CyBOR-D, and it was demonstrated that the VTD was superior in terms of both progression-free and overall survival. Now, in the United States, VTD is not used very much anymore, but we can abstract that information to suggest that VRD, which is commonly used, is likely to be better than VCD or CyBOR-D, and that establishes very firmly that VRD is the treatment of choice for induction of patients with newly diagnosed multiple myeloma. And finally, the French updated their early versus late stem cell transplant, demonstrating that patients who received an early stem cell transplant had both improved progression-free survival and, most importantly, improved quality of life, which strongly supports the use of stem cell transplantation. So it's no longer a question of novel agents or stem cell transplantation, but harvesting the advantages of both techniques in optimizing the management of our multiple myeloma population. We're very excited about this information, and we believe that the future is very bright for our patients with multiple myeloma. Thank you.